All right, hello. I'm Chris Thompson, and this is Jim Slattery, and we're at Brigham Women's Hospital, and we have an Apollo OverStitch case today involving endoscopic gastric bypass repair. This particular patient is a 50-year-old female who had a laparoscopic Roux-en-Y gastric bypass in 2005. Her weight went from 236 pounds to 133 pounds in a little over a year. Now, over the past several months, she's managed to put back on about 40 pounds, and she's having problems with poor satiety. An upper endoscopy was performed and showed her pouch to be roughly 4 centimeters in length. However, the outlet was significantly dilated at over 4 centimeters. We try not to burn the small bowel, in particular here. We're not really sewing that, we're sewing the stomach side. So you can see we only have a little bit of room left before we get to esophagus, so I think that's probably pretty good. Now, we want to evacuate the argon gas. That's just going to cause some crampy discomfort later. So we're going to go now and we're going to aspirate this out. Get all this argon gas out. I go down into the limb and get that out. Then at the end of this, I like to instill some methicone. And we do this for pretty much all our procedures. I like doing it after the APC because when I go down to aspirate out the argon gas, I usually suck up all the simethicone again if I've already placed it. So I like doing it at the end. And the simethicone works great. It's a liquid formulation here. And you can see we mix it so that it's a light pink color. Okay? And then we're going to just instill that into the roux limb here. This is fantastic. You know, the other word for this is gas X, and it really does help absorb any of the air or gas that's left behind and allows them to wake up more comfortably. So that ends the preparation phase of the procedure. We've gone down and done a quick surveillance endoscopy. We've placed the esophageal overtube. We've ablated the mucosa around the gastrojejunal anastomosis, and we've also placed simethicone. So now what we're going to do is we're actually going to take a bite. So for the purse string technique, I like to start down at about 6 o'clock, and I place the device such that that suturing arm, you can see right there, is just on the other side of the anastomosis, just in the bottom lip of the anastomosis. I'll then push it in so it looks like I'm getting a good deep bite, and then I activate that handle. Just close it until it clicks. Now, to take that anchor or that needle from the curved suturing arm back to the anchor exchange, we simply go down with the catheter, we go down with that anchor exchange until it bottoms out and I feel resistance, and then I pull back. Now, when I pull back, I should feel considerable resistance. It mounts and then it releases. Now I know I've gotten that. Then I just activate the handle again. The curved suturing arm is again released and opened up, and you can see I have a nice bite there. So now what we're going to do is reload that curved suturing arm. We're going to close it again by activating the handle, advance the anchor exchange. Again, push that blue button, pull back ever so slightly to put that needle back on the curved suturing arm. We're going to activate the handle, open it up again. Now we're going to move on and we're going to take our next bite. And so if our first one's at 6 o'clock and we anticipate maybe getting 6 stitches around here, the next one will probably be around 4 o'clock. We're going to kind of go in right here. I tend to use less suction during this, kind of bring it down a little, or less insufflation, a little suction here, bring it down. You can see that's a good deep bite again. Activate the handle, push the anchor exchange down, pull back, activate the handle again to release. I've got another bite there. All right. Now I'm going to have to reload. Again, activate the handle, push the anchor exchange down, transfer. Okay. And we're going to take a next bite. The next one, I'm going to try to come up maybe around 2 o'clock. I want to make sure I get enough play in this as well. I want it to run with me, but not too much slack so that there's problems. So I'm going to come in maybe right around here. Now here it helps to torque a little bit. All right. It gets harder as you get more towards the top. So you can see Purse string is running around fairly nicely right now. I keep picking up that suture on the right of the visible suture so that it runs pretty freely. You can see it's running pretty freely here and it's not locking on me. Now I'm going to go all the way up to about 12 o'clock. Again, pushing the anchor exchange down, picking up the needle, backing up. All right. So you can see that purse string is running nicely around there so far. I'm going to keep going right now. I'm going to kind of come over to this area. Moving my way around, maybe around 11 o'clock right now. Bigger stomas require more stitches. Additionally, the longer you run this, the more resistance you get. See, that's all coming together pretty well. Pick it up again here. Keep going to the right. Hoping that makes it easier. No guarantees. All right. So now we're coming around with our purse string. Now I like to flip on this side. I like to flip that to the bottom. Okay, as I'm coming to my 3 o'clock shot, I like to flip that to the bottom. I feel like it gives me a better, bigger stitch. A little deeper there. And I'm going to come in here maybe around 7 o'clock. All right. And then we're almost all the way back to our 6 o'clock initial shot that was at 6 o'clock. I think I'm going to do one more here. One more right next to this. Sometimes I actually go over this. Right near there. Just a little bit on the other side. All right. So now we come all the way around with that purse string. Now what we're going to do is we're going to cinch this together. So, and that was, how many stitches do we put in there, guys? We went from 6 over to 4, up to 2, up to 12, over to 11-ish, over back over to 9, down to, I think we came down to 7, and then back over to 5 again. So we put plenty of stitches in there. Again, your target is you want to get 5, but if you want to go to 8, you know, that's fine, especially with a bigger stoma like this. All right, so now what you're going to see is we're going to eject this. So to eject the needle or the anchor, what you're going to do now is, if you watch my hand, you're just going to push on this blue button, kind of jiggle and pull back, right? So I like to put it under a little bit of tension. I feel that it pops out better that way. And you'll see simultaneously on endoscopy how this is done. So I just push that blue button, jiggle a little, come back, and you can see on the endo image the tag or the anchor is right there. Yeah, what's unique about this procedure is we also put a CRE balloon down, and it serves as a bougie so we can really very nicely size the gastrojejunal anastomosis. And now what we're going to do is make sure we're back far enough so we get the entire anastomosis in here, right? We want to be able to see it as we do this. And now what I'm going to do is we're going to swap, and Jim's going to take charge of the catheter and put a little positive pressure on that. And I'm going to pull this suture until that purse string closes down around the balloon here. You can see that snugging down nicely. Now I use a good bit of pressure for this part, right? I'm using my thumb, if you can see in the room shot. I'm using my thumb to put tension on it. I kind of relax it a little, and I hold steady tension. It's got to work through, right? I like to push that balloon down a little more, make sure it's in a good spot. Looks like it's in a good spot right there. And I secure this. Now I think that that is pretty good right there. Then before he's going to cinch that, I like to release the tension a little bit, because I don't want there to be too much tension on this. Otherwise, it can just pull through, right? You don't have to kind of cheese cut through. So I'm just making sure I get that suture to work its way all the way through those loops of tissue. Then I relax it a little bit. And then when I relax it right there, if you can see, that's about how much tension I have on it. It's loose. It's not like a guitar string. Right? It's kind of loose. If you're looking at my hand there with that stitch. It's not really tight like a guitar string anymore. I did that to get it in position, get it secure.
The cinching device has a very nice little safety mechanism in here so that you don't prematurely deploy the post and circle. So what you need to do first is open your hand and drop, and then just squeeze. And now we check to make sure that everything looks right endoscopically, and I'm holding pretty firm pressure against Chris's pulling.
All right, so I'm tightening again just to make sure it's good, and I'm loosening a little, and he's going to fire right now.
All right. You can let go at that point and use two hands.
So we're back down here, and now we're going to reinforce that outlet. You can see there's our opening right there. So we're not going to get too close because we don't want to close this off completely. We're going to work back a couple centimeters, okay? And we're going to do a series of kind of interrupted stitches. So I think first I'm going to just put a couple stitches in over here. So I like working low to high, so I'll find that fold there that I want to kind of reinforce, and I'll kind of come in right about there. Put my first stitch in. Again, activate the handle. I just push my anchor exchange down and back. I don't push the blue button there. Then to reload, I'll again activate the handle, anchor exchange comes down, and you can see it kind of attaching to that curved suturing arm. Then I push my blue button. So the blue button puts it on the curved suturing arm, and I'm going to go up and take my second bite here. So putting it into this fold, right there. Again, anchor exchange down and back. I'm picking it up in the anchor exchange, no blue button. I got a nice interrupted stitch. I'm going to come over with my curved suturing arm, reload, anchor exchange down, then I push the blue button. All right? So that's a nice little interrupted stitch. I'm going to probably, and you can see I'm close to the outlet right over there, but I'm not right on top of it. I'm going to come down because I like to get my second stitch kind of near the first, or my final stitch near the first. Come right in there, anchor exchange down and back, open the arm up, I'm going to come out. Now this is a good situation to show you. I have a stitch, if you see, over my device, all right? There's a stitch behind my device. If you look at the endoscopic image, you can see it running up on the right of the device, disappearing, and then coming out on the bottom of the screen. If I pull back, oh, it feels like the device is stuck. This can happen a lot if you're working in tight spaces. So what I like to do is push out the anchor exchange a little, okay, try to create some slack. I like to pull back the device a little bit, but then what you have to do is you have to close that suturing arm. So you get a gap where you can kind of close that suturing arm partly. You can't close it all the way because the anchor exchange is out. And then you manipulate the device down and back over, and you'll free yourself pretty quickly like that. Again, you don't lock it because my anchor exchange is out part way, okay? So now what we're going to do is we're going to secure this. So I push the blue button, I jiggle the device, it releases that little anchor. My assistant's going to take that, and we're going to have an interrupted reinforcing stitch there. Again, whenever I come out with that anchor exchange, I cap the suction valve because I don't want blood spurting all over the place, and I like to see what I'm doing. So now as he's ready with the cinching device, I'm going to uncap that, and we're going to plug that hole up pretty quickly, and we're just going to run this device down over that suture. All right, so now I'm going to look at where the stitches are emerging, kind of in the fold right below me there. So I think it's going to end up being right about there that I want to be. So once I figure that out, I swap with Jim. I take the suture, he takes the catheter, He has charge of the catheter now, and I have the suture. I'm going to pull a little bit, pull it together. I don't have to pull as hard here because it's not a big purse string with many, many bites. It's just a couple of bites here. So I'm going to pull. It looks pretty good. Not a guitar string. I do the guitar string initially to make sure I get all the slack out of it. And then I kind of relax it, and he's going to cinch this again, just like he did before.
Drop the safety tag, squeeze, and now you can change and use 2 hands. And just snap it.
He pulled out the stitch as well. And then I cap that. All right, so that's a reinforcing stitch, you can see. Now I'm going to do maybe 1 or 2 more of those. Again, we load the anchor exchange down with the needle and the suture in place. I'm going to activate the handle to close the curved suturing arm, push the blue button to release the needle, and then we're going to open it up. Now, there's not a lot of slack there. I tend to like more slack if I can have it. So I'm going to actually close and do this again. Well, actually that's not too bad. I'm going to close and do it again. So again, I basically activate the handle, push the anchor exchange out this time, get a little more play in the system if I can. And then repeat. This is a little bit better. All right, so now I'm going to look for another spot to do some reinforcing. I'll probably go low on this now, or maybe over on the right. So I'll put my first stitch here, and then maybe my second stitch up there. I don't want to go in that outlet. See, things are closer than they appear, just like a rearview mirror sometimes with an endoscopy. And if I aim here, that needle could go into the into our new outlet, into our new stoma, and that's going to make things tighter than I want them to be. So I've got to back up, maybe go even further back than that cautery margin. You're right about there. Go down with the anchor exchange, pick up that tag, open the handle up. I'm going to reload again, reload to the right of my suture so I don't get a knot or a cross stitch. Open it up, have a nice gap there. Now I'm going to go up to the right and grab that other fold up there, and we can bring that down. Again, I'm not too close to that anastomosis, otherwise it could become too tight. Again, close the arm, come back, open. So you have a nice kind of reinforcement there. I'm going to reload one more time. Careful not to catch tissue. All right, and I'm going to come down one more time. I like doing 3 bites to do this. All right, there we go. So now what we're going to do, we're going to drop that tag again. He's going to pull out the anchor exchange, and we're going to cinch this. All right, so I think that's a good position for that. So we're going to swap. I'm going to take the suture. Jim's going to take the catheter. And you don't want the catheter out too far or back too far. You don't want it to come into the device or it won't work. So we have it out just the right distance, just about 1 centimeter beyond the suturing device. And I've pulled it kind of tight like a guitar string to get out the slack. Now I'm loosening it, and now he's going to cinch it. There we go. He pulls out the cinching device and the suture together. And we're going to cap this. And he's going to get another stitch ready while I look around. Keep in mind there's a little edema here, so things are going to start swelling up and looking tighter than they are potentially. I like to do one more reinforcing shot if I can up above. Maybe here to here. So there is another device you could use called a helix that helps get you deeper stitches. We're going to show that in another training video. as I don't think we need it for this case. This case is moving pretty smoothly, and we actually just didn't really need to use it. It is very helpful, and it does help you get deeper bites when you need it. And we're going to show that again in another video, but I don't think we quite need it for this one. This is kind of complicated enough with what we're doing here. Again, I do a two bites, kind of an interrupted stitch there. I'm going to come back one more time to this other side. I want to make sure I get deep enough there. I'm going to suction a little, take all attention out of it. That's a good deep bite. Don't want to be too superficial over there. I was a little worried about that. So now we're good with that. Again, we're going to eject that tag. I'm going to cinch this down. Okay, now we're going to cinch. Again, when you have the cinching device out, you can see that little lead or the post that's going to be pulled into and secured into the cylinder. Sometimes if it's going in right at 90 degrees, it kind of, there's resistance there. So you have to find a way to get it to go tangential like that, kind of ride over the tissue. Don't just push it into the tissue. That can lead to a premature securing of the suture. So then I'm going to swap. I'm going to take the suture once I get that in place. Jim's going to hold pressure on that catheter. I'm tightening it up so to a point where I like it. Guitar string tightness, but then loosening it, and then he's going to secure that now. Very nice. And he pulls out the suture and the catheter. All right, so that's it. We've done our outlet with a purse string, and then we reinforced it with stitches around the new outlet, and we're left with a 1 centimeter anastomosis. So this should do the patient quite nicely. So I'm happy with that part of the procedure. Now we're going to work back, and the pouch is a little big over here, so I think we're going to bring that down a little as well. So I'm going to probably grab tissue from down here and bring it up to here. All right, so I'm going to take my first bite. I'm going to grab it right about in here. So again, activate the handle, anchor exchange, have the tissue there. Going to reload. Very simple part of the procedure here. You just do that over and over. You get good at it quickly. Now I'm coming over here, and I can't really grab this too easily, right? I'm going to have to push into it if I want to grab it, and then I worry about grabbing other tissue as well, because this is a full thickness suturing device. So instead, I want to use our helix device to grab that tissue and pull it to me. So now I'm going to insufflate here a little bit, get my bearings. You can see my stitch behind me. I don't want to go too terribly far away, maybe over here. So now we're gonna open up that helix, and we're going to the tissue, just a few cranks. Go ahead. I like to try to watch it if I can. Now, as soon as I see that tissue turning is when I stop and see if I've got enough tissue. I go a little more maybe. Beautiful, that's enough. Now, notice how the tissue comes back to me pretty nicely. If it was moving as a block, I'd be worried I've grabbed something on the other side of that. But it's not doing that, so I'm pretty happy. Now what I'm going to do is turn my device. I turn my wrist towards the patient's feet to turn my device into this. Sometimes I'll have the assistant actually pull back on that helix for me so I can get this fully into the jaws of the device. And then I activate my handle. I have a nice full thickness bite there. All right, so now what he's going to do is he's going to, I'm going to take a bite first actually. I'm going to exchange that. I like to do that. Now what he's going to do is I can push out and I can wash this. I prefer to wash this. I wash it deep, kind of torque there, and I come back at the same time. Because if you turn too quickly, it is possible maybe you'll get tissue ensnared in that device. So I like to watch that part of it. So now we have grabbed that tissue nicely. I'm going to come back and put one more stitch in the proximal amount of tissue there. One more stitch right here. And then we're going to secure this. See that come together nicely here. All right, so again, I drop my tag. It's important to keep those sutures visible so that you don't get them tangled or you don't get the device ensnared in them, especially if you have long running stitches, very big pouches. Communication is important. Jim and I have done this together a long time, so we don't necessarily talk as much as you should be talking with your assistant as you're doing these procedures. I know he's comfortable with this. So now I'm going to pull those two together. You can see them really come together nicely. I pull real tight initially, just kind of hold constant tension for a little bit to make sure it all, you get all the slack out of it. Then I'm going to loosen it up a little, and he's going to cinch it. Nice. We cap the suction valve there, the access channel valve. Now we're probably going to do one more stitch here, overlapping that, and we'll probably be done pretty soon because this is our esophagus right here. You can see kind of the Z-line coming into view. I don't want to get up much more than that. It makes it harder to cinch because you have to sit in the esophagus with your device, and then the lower esophageal sphincter will pinch and it'll be hard to see. So I don't like going beyond that. Probably come in over here. Activate the hand and we'll place a stitch. It's a very deep stitch. If you're going to get bleeding during these procedures, this is usually the spot you're going to get it. And usually you can stop it just by securing the stitch. So just move quickly and methodically, but you want to secure that stitch. Don't stop the procedure and worry about getting epinephrine or anything like that. It's always good to have it in the room, obviously, but... So another way to grab this, as I'm trying to demonstrate a little here, is you can actually kind of suction a little and turn your device, and sometimes you're able to grab a nice full thickness bite like that as well without using the helix. We'll see if we can demonstrate that. See, look how hard that is though, right? It's very tangential. I'm going to have to go in, I'm going to have to turn the device over about 90 degrees, and then I can get that fold into position. I suction a little, and that does allow me to get a nice full thickness bite. But that's tricky, and you can't always do that. That's why the helix is very helpful at times. All right. I'm going to come back to here, I think, when we'll be done with this one. I'm releasing the tag, and we're going to again cinch this. A few other things to keep in mind. We like to assess the patient's abdomen as we go through this and make sure it stays nice and soft. We are using CO2, so it'll be absorbed readily. Additionally, the patient did have a bowel prep the night before. This prevents code browns, of course, during the procedure. People will have large, loose bowel movements during this procedure. We're putting a lot of CO2 into the abdomen. So we like to do these things to try to minimize those issues, and additionally, it makes the patients far more comfortable when they wake up. And we're done with that. So now that looks pretty good to me. So what we're going to do is we're going to swap this scope out. All right, we're going to go back down with the diagnostic scope, clean out any clots, take a look around, and we'll cover some post-op care while we do that. When you pull this device out, one thing you've got to remember, all right, is that you always close the device, right? You don't just pull it out without closing it. So again, now we're down in the pouch, and we're looking at our work with the diagnostic scope. There's a little clot right here. That's okay. Expect to be a little clot. So here we are. I like to look at the esophagus, make sure we didn't do any damage to it. I don't think we did at all. We weren't really in the esophagus much. We came out only a couple of times to clean things. Here's the lower esophageal sphincter. And then now as we come in to the pouch, you can see it's much tighter. I'm riding that air right there, and you can see I still have a nice pouch over there, so there is a bit of a reservoir. But it certainly is more narrow, okay, as far as north to south goes here. Then when you turn and come down, this is the area for gastrointestinal anastomosis now. All right, now there's some edema, so it looks a good bit smaller than it will be. But that's the anastomosis right there. I'm not going to force my scope through it. It will settle out to be 1 centimeter. And I'm very happy with that. And you can see our reinforcing stitches around here. There's no other gaps or any kind of funny thing going on here. Now, you'll notice this is very tight. It's going to keep getting tighter. This anastomosis will get tighter over the next 24 hours right here, okay? So that's important when you're considering what kind of diet you're going to send the patients home on. Okay, that anastomosis is a good bit smaller than a centimeter right now. So what I like to do is I load them up on IV fluids, and I tell them to be NPO for the rest of the day. All right? Then tomorrow they're going to start clears, and they're going to be on clears for a few days. Okay, and diets vary, but I like to keep them on clears for at least 2 days. Then they go to full liquids, and those full liquids last, depending, 2 to 4 weeks. All patients seem to tolerate 2 weeks just fine. They're very comfortable with that. They're getting the protein shakes in. And many do ask to prolong that and go on to 4 weeks with the full liquids. If they so desire, that's fine. But I'm looking for a minimum of 2 weeks there. And then we go on to softs. And additionally, you have to make sure that patients that take important medications have those medications converted by their pharmacist to their prescribing physician to crushable or liquid solutions. Because certainly big pills will not fit through this for the next few days. So I make sure they have about a month's supply of that. And again, I already did mention the bowel prep and NPO at the time of starting that bowel prep. So I'm pretty pleased with this. You can see the pouch and the anastomosis certainly are much smaller than they were when we started. And I think she's going to do quite nicely.